tell us when you're ready, Dad.
Yep.
Go ahead, Dr. White.
Okay, here's what we'll pass around first, just so you guys know what this is. This is an IVC filter. You guys pass that around. So what an IVC filter does, well, first of all, the purpose of an IVC filter is to prevent migration of distal clots proximally into the pulmonary artery, which is what leads to pulmonary embolus. You just look at the anatomy diagram, just remind you of what the anatomy of the venous return is. And what a DVT is, a deep venous thrombus, is when you get a blood clot in actually the iliac veins or the femoral veins. Clots below the knee are not deep venous thrombuses. So clots below the knee are small, and if they embolize, don't usually cause massive pulmonary embolus. And you can see from the size of that filter, the clot has to be about that big to kill you. So actually, clots below the knee can sometimes be managed just very conservatively without Coumadin. But clots from here to here, if you get them, have a high risk of embolizing to your lung and causing fatal pulmonary embolus. So the mainstay of treatment for DVT is anticoagulation. So why were filters invented? Filters were invented in people who can't tolerate anticoagulation, who have DVTs. So the standard indication, really the only two indications for a filter are, number one, an active DVT with inability to tolerate anticoagulation, or an active pulmonary embolus with inability to tolerate anticoagulation. And initially, the only way to put in a filter was surgically. So you slice open your abdomen, cut open your IVC, and cram that filter in. So hardly any filters got put in. But now we can put them in percutaneously, and they're real easy to put in. And so with that advent, the indications for filters have gotten a lot softer. And the number of filters that have been put in over the past 10 years has increased by over 1,000%. And so that's where all the problem comes in. So now people that have softer indications, like for instance someone that comes in with trauma, who has contraindication to anticoagulation because they've had trauma and they're at bed rest, so if they're high risk for DVT, there's some trauma surgeons that will recommend putting in a prophylactic filter in these people. And people, the other indication that we're seeing a lot of that's kind of a soft indication is people that are having orthopedic surgery that have had a recent DVT within the past year, and the orthopedic surgeon will feel that their DVT risk is too high and they'll want a filter put in to bridge them during the time period they can't have anticoagulation. So part of the problem is that people are putting in filters for kind of softer indications. Just so you know how we do it, if you see that thing, it's a really cool device. And you can see what it's nitinol, so it's compressible. So when it gets compressed, you put it on a sheath and it compresses down. You take put an access site, usually in the femoral vein or the internal jugular vein, and take a picture and see where the renal veins are, and you put that filter right below the renal veins, so it just expands. And so the complications from it, it's real easy to put in general, it goes real well, but sometimes if the inferior vena cava is too big, that only expands to a certain diameter and it pops right through the heart right away. So to put the filter in, since the venous stick, if they are on anticoagulation, which theoretically they shouldn't be because they can't tolerate, but if they are on anticoagulation, sometimes they are for a surgical filter, you don't need to hold anticoagulation prior to putting it in. So what's the big controversy about it? Putting it in is easy, it seems to work. The problem with them, if they stay in, there's a lot of potential long-term complications with them staying in. You can see from the barbs on there that one of the main complications is that they can erode through the IVC because they have barbs on there. So long-term they can erode through the IVC, they can clot. If they clot, it's big time trouble because then you don't have an IVC anymore. You get massive edema. And ones that you're getting sued for, the old Baird filters, used to break loose and migrate to the heart. So there's two people that are watching. So if you put a filter in, would it ever come out? The answer is yes. And that's kind of what all the fuss is about. We want to make certain, because of the long-term potential complications of the filter, that people that get filters and potentially can have them removed are identified and have those filters removed. So for instance, if a young guy came in with trauma, and he had an active DVT, and he got a filter placed, then when he recovers from that trauma 3 months later, he can have his IVC filter taken out because he no longer has the risk factors. Or if a person comes in with an active ulcer and an active DVT, and you put them on heparin and they have a GI bleed, you fix the active ulcer in 3 months, they no longer have contraindication to anticoagulation, they can have their filter taken out. So there's lots of subsets of people that can have their filter taken out, and we want to identify them. What's been happening is that when radiology would put these filters in, they would put them in, the person would be comatose, they might not have family members, and they'd go home 3 months later and didn't know they had a filter in. And they show up a year later with swelling in their feet, or someone takes an x-ray of their abdomen and they've got a filter. So that's bad news, because after a year, the filter cannot be taken out.
What's the reason that it can't be taken out after a year, Dr. Why?
Yeah, so just, have you ever seen what like with a stent, after a stent, endothelium grows around it? That's the same thing that happens to those filters, is that it gets endothelialized, and those barbs are in there. And when you take a catheter down to try to pull it out, it just sticks. So you just tug on it, you can see the whole interfering cable moving.
So the only filters you put in today usually are the ones that can be taken out.
So that's the thing, if you look at that handout, that's where a lot of so the hospitals, most doctors don't even know this, is that a temporary filter just means it can be removed. But if it's not removed, it's a permanent filter. So from our standpoint, we don't see an advantage to stocking. There are filters that cannot be removed. You put those in people who it's clear are going to have ongoing contraindication to anticoagulation. But from our standpoint, we don't ever put those in. So we just stock temporary filters, knowing that if we put them in for more than a year, they're a permanent filter.
What's the national statistics on how many of them are taken out?
So it depends on what you look at, but it looks like about 34% are taken out. And then if you develop a program to monitor and track the people, 75% of them come out.
And we're starting a registry. Actually, Denise is keeping track of it now, but we're starting a registry so we can track them more effectively.
So it's real important that these people be tracked for, and then the most important reason is that it's best for the patient. So we just recently saw a 27-year-old guy that had traumatic DVT and pulmonary embolism. He got a filter put in by radiology, and then came back to see us about 2 years later with massive lymphedema. So he's 28 years old and has a clotted filter, and nothing he can do about it. So he's got massive lymphedema for the rest of his life. And lots of times, it's amazing how this gets lost in the shuffle. You'll be doing a cath on somebody, and do an x-ray on them, you see an IVC filter. You say, did you know you have a filter? And they say no. So it's essential that we track these filters. And the ideal time for taking them out is 1 month to 3 months. At 6 months, it's a flip of the coin. At a year, I've taken one filter out at a year, and it was not pleasant. You can see, and if you look on the filter, it's not rocket science. They have a little basket, and the tip of that basket, there's a little hook, and you just put a wire on that hook, and
it collapses it?
It collapses and pull it out. And even after 3 months, when you pull it out, there's endothelium on the little struts. So after a year, you risk just taking the whole PPG cable with you.
So is this an outpatient procedure usually?
Yep. So for removing the filter, so for most people so there's two people that would have their filter removed. One would be a person that had a DVT for a reversible cause. Grandma was on a car ride to Florida, stayed in the car for the whole ride, got to Florida, had a DVT and a pulmonary embolus. She got put on heparin and had a GI bleed, and so she needed a filter during that time period. But then after 3 months, grandma's not riding in the car anymore, so her risk factors have been removed. So she can have her filter out and doesn't even need Coumadin long term, because she had a reversible cause for her DVT. The other type of person that could have it removed would be somebody that has a clotting disorder, but for some reason had a GI bleed from a reversible cause, and then once that reversible cause is treated, they can tolerate Coumadin again, so they can have the filter moved. In those people, once they're stable on their anticoagulation for a defined period of time, they can have their filter removed while they're on anticoagulation since the venous stick. So if someone's on Coumadin and they're going to have their filter removed, or they're on Xarelto and going to have their filter removed, they don't need to have their anticoagulation stopped prior to removing it.
So when you put these in, do we, upon discharge, do we go ahead and schedule an appointment for them to come back, or it just depends on what's their situation?
There's two problems. We've looked at the registry and it's not great data, so we definitely need to tune it up. There's two things that can happen. So if the guy gets, the most common reason people get lost is because they stay in the hospital forever because they had this traumatic experience, or they're older and don't remember getting the filter, and so by the time they get discharged from the hospital, maybe 3 to 6 weeks later,
We've signed off or whatever.
Everybody's forgotten they had a filter. So the program to do it is at the time of the implantation, a follow-up appointment in the vascular clinic with Ann needs to be arranged. And then if that person is a no-show for the vascular clinic, it's going to have to be our responsibility to track that person down and make sure they show up for their appointment. And then when they're seen in the vascular clinic, at that time, Ann will determine with our help, we made at that time say, oh, this is going to be permanent, documented, and there's a good reason for it staying in, or it still may not be known whether the filter can be taken out, so we'll have to follow up in several weeks, or we'll arrange to have it taken out.
If a filter has to remain in, is there anything else we do with them, or they're pretty much, that's it?
That's it.
Okay.
And theoretically, it looks like that should be 25% of the people.
Mm-hmm.
In the follow-up, like let's say Ann sees him and you still are undecided, should the follow-up, Ann make the follow-up in the vascular clinic or back to the primary?
Vascular clinic. So we need to describe it, because a few people kind of have this vague understanding of filters. There's physicians that don't know filters can come out. And there's people that don't understand the long-term ramifications of having a filter in. So we definitely, the vascular clinic needs to track that person until either we say it's permanent or it's come out.
So let's review what type of procedures, or I should say, what type of physicians would order these the most?
So now it looks like it's the hospitalists. And so the service that we provide is when the filter goes in, it's twofold. If we put it in, we're going to track it. But probably even more importantly is we can make sure that there's a good indication to put it in. The problem is they're so easy to put in. The patient goes down, they come back up, it's a venous stick. So they're so easy to put in that there's a tendency for people to overuse them. And so we can help them make sure they have clear indications for putting them in, and then once we put them in, we can track them.
And then do trauma surgeons get involved with this?
Trauma surgeons, I asked the trauma surgeons, so part of the problem too with the indications is the trauma surgeons have one indication and the American College of Chest Physicians have another indication. So there are and I talked to Cobb about this, and they're supposed to come to kind of consensus what they think is there's some trauma surgeons that think anybody that's had significant trauma should have a filter placed prophylactically. When you look at that in trials, all that does is increase your risk of DVT. So the trend has been not to put those in prophylactic, but there's still 1 or 2 trauma surgeons that want to put in.
And then the orthopedic surgeons, for major bone, like hip and...
So that we're willing to work with them, because for those, they're clearly going to be temporary.
I would say the higher one is oncology. So what I'm seeing is the hospitalist number 1, 2 is the trauma surgeons, but almost oncology is above the trauma surgeons.
I was going that direction.
And we're trying to educate Margaret and them to let them know that we are putting them in and we are following those patients.
And tell me why the oncologists would be ones putting them, or ordering them, I should say.
Right, and then
What's the reason that they would order?
They do because the patients are on chemo.
See,
and
those are, there's different volume.
Absolutely, and then Fort Wayne Neuro orders probably more than the trauma.
For,
They order a lot as well.
okay.
And we don't place them on, just so everybody knows, we don't place them on weekends.
Well, we do if someone's on call, but.
Right, but if there's not, tell them which doctors place it, they probably.
So here's two things. Number one, during the weekday,
Mhm.
we always want to put a filter in, period. So there's, if someone calls and says they need a filter, then you should call one of the peripheral guys. If you're a triage nurse, you can call one of the peripheral guys, and we'll assess the situation and put it in. A non-peripheral guy could see the patient, the peripheral guys put him in.
And
But
then,
we always want to put them in. So if someone calls, we're always going to put it in. We've told them that.
and then on weekends and holidays, if we don't have a peripheral guy on,
Well, that kind of works how we do peripheral cases. They'll call us on the phone.
are we supposed to call for an IVC filter?
What you do is you call the interventional guy. Interventional guy will call us if we're around. If not, then there's a chance radiology put it. But that's how we cover peripheral cases, acute peripheral cases too. So if someone has a cold leg, that's how we do it on the weekend too. So there's 4 peripheral guys that are able to put them in. Same with an acute leg. If someone has an acute thrombus in their leg, they call over the interventional guy and then they try to get a hold of us, and the radiologist does it if we can.
Because I noticed with the stats that I was keeping that once a month, there was once or twice a month, there was at least ones placed in a holiday or the weekend that IR was placing.
We have a relationship with IR that they don't complain about that anymore. So I think that'll work out already.
How do you know what size? Like when you said that.
There's only one size, so that's, the nitinol's a super cool thing. I wish I invented it. It's crimped and then it can only expand to a certain size, so you can't size them. So when you take a picture of the inferior vena cava beforehand, you have to make certain that it's not too large. If it's too large, it expands. If it doesn't expand anymore, then it goes to the heart. But obviously, that's 30 millimeters for one filter and 28 millimeters for another.
If it goes to the heart, can you retrieve it percutaneously?
Yeah, I've seen one old filter that embolized to the heart, and it went up to the heart, and the guy didn't even know he had a filter, and he came in because he had a murmur, and it attached to the intraatrial septum and eroded through. So that's what his murmur was from. So that had to be taken out.
Surgical.
So if you decided the IVC was too big and you couldn't use a filter, what do you do?
Well, you know what they used to do, the original surgery was ligating the IVC. So that's, then you create a lot of problems there. So that's why, the good thing about technology, it's really easy to put them in. The bad side about technology is since they're so easy to put in, you have to make certain that you stick with the indications. So when you had to ligate the inferior vena cava, you wouldn't have put it in before your orthopedic surgery. And so if you look at those data, if you look at the benefit of filters prophylactically, meaning no active DVT, it's hard to prove a benefit. So that's a service that we offer in making certain that the right person gets a filter put in.
So Denise, what's the implications for the rounding nurses?
Well, I think the big thing is I did communicate with anybody that does triage that we definitely want to check with the peripheral doctor that's available to try to arrange that IVC filter within the working day.
Which we'll do, period.
Yeah,
Period.
and yes,
So that we should,
and
if
it's
the
on the
filter
list
is
now.
requested during
Right.
the weekday,
Right.
we will put it in,
Right.
period.
And then the doctor that places the filter will notify the discharge nurse or his nurse or whomever, and I know Jessica does this a lot, is she sets up an appointment with the vascular clinic with Ann, post-op. And the orders, I have it all outlined, everybody received this paper. If you don't have it, I handed out a long time ago, it was last updated on February 11th. You have to open a case. We are in the process to help the hospitalist and I want to show you that today before you leave. Ethel has developed an actual order in Epic. The order, because the hospitalists, they don't want to call triage. They want to be able to put in an order like they do for IR. So they type in IVC filter, and how Ethel and I finagled it is it's the first one that pops up. Cath for us to do, and then IR.
Well, C becomes
And then-
before R, cardiology,
Yes,
radiology,
yes.
so that
They'll
makes
see
sense.
us first, and then what it'll do is when they complete it and sign it, it falls into a work queue for Candy and Deetra, and then they will call triage, just like they would now. We place the order and we go on.
And then,
And that's in the process that after he looks at this and approves, it'll be built, it won't take long, and then I will send out a voicemail saying that this is in there.
you'll evaluate to make sure it's appropriate, the person that's gonna put it in?
Well, I think the
What
only,
I've told the hospitalists is that so there's two things we can do. So number one, they may ask for a consult. So I've told them there's two paths they can do. They may ask for a consult, which if they do that, then preferably a peripheral guy would see the consult, but a peripheral guy wouldn't have to see the consult because all cardiologists should know the indications for a filter. So if they ask for a consult, we'll evaluate him and decide to put it. It's fairly straightforward. We don't necessarily just see him beforehand. Then a peripheral guy would just see him in the lab and then put it in.
and if they're greater than 90, we definitely, that the requirement was if they're greater than 90, we notify the peripheral guy and he makes the determination.
So what kind of patient education do we do when they leave?
That's
Anything?
Well, the thing is what's in Epic is pretty awful. So I'm like to try to develop a smart phrase and
Okay.
kind of summarize it and just have a few bullet points,
What
but
would be nice to do, like,
it's not the best.
I was thinking about that actually. If there's the ones that are able to take out 75% of the filters developed. You know, when you have a stent put in your heart, you get a little card,
Right.
Cordis, that says, "I got this little expensive stent in my heart." We should.
I think it'd be worthwhile to
We
do
need to
that.
develop some sort of thing. It'd be nice to develop some sort of thing that a patient gets when you put the filter. The problem is they'll still lose it.
Well, it'd be one more reminder, though.
Well,
I
I'm
mean,
wondering if
no.
it's within the package
I'm
upstairs.
surprised they don't. I was thinking that.
I could
last
ask
night,
Tina.
I'm surprised that they don't have when you get
I like that idea. It gives, a family member or somebody might remember,
The key, like I just saw a patient in the office in vascular clinic that had not come back to follow up and had a filter in it a year and didn't need it because he was tolerating anticoagulation. And the reason he kind of got lost to follow up was there's a lot of reasons for it, but one of the reasons is usually if you're getting a filter put in, you're pretty sick. And so in that 3-month period, there's a lot of hassles that you're going through.
Sure.
So our job has to be to make certain that we're pretty vigilant about calling that patient back and making sure they come for an appointment.
They could be at a nursing home for that matter.
We
They
do.
could be anywhere.
We have a couple patients that are in nursing
Yeah.
homes, in hospice too. Are these MRI compatible?
There are MRI. The answer to that has not been studied, but you can. The reason here's the thing is that the reason you can't do an MRI like for pacemakers, it's not because you yank the pacemaker out, it's because it heats up.
Yeah.
And so this theoretically should be all right with an MRI, but they probably wouldn't do it.
So do you have to do any imaging prior to taking this out, or you just take them to the cath lab?
You do an image to make sure there's not a big clot burden there. If there's a big clot burden,
You just do a fluoro image?
no,
Oh.
the vena cava.
Oh, okay. Okay.
But sometimes even, I've had some you can't take out because they get tilted. It's not this. This is good we're doing this because they're so easy to put in and forget about, and then you do a lot of people a disservice. One of those handouts I gave you when I was searching last night on Google, the first thing you get when you Google IVC filter is 3 law firms.
Yeah.
No, it's
Well,
true.
you see it on TV,
Have
commercials.
Have you had a permanent filter
Yeah.
put in? Please call us.
Yeah, they're all over it.
Well, we're liable for that.
I know that.
If a guy has a permanent filter and we haven't followed him up, then
That's why this registry, I think, is extremely important in what you're doing. So do you track this on a weekly basis then?
Well, I
or
try
how-
to do it every week or every other week, but there are a couple that we attempted to remove and were unsuccessful. And then I put permanent, and I put in the documentation, attempted, and then the date and unsuccessful.
so it'll be documented. It's permanent. It'll be documented that we tried to remove it and couldn't, or we removed it. that's how the filter should be finalized.
And do you have any feedback about the patients you see in the vascular clinic?
Well, a lot of times the appointments with me are within like a couple of weeks, and the patient's not ready, they have it taken out. And there's a few, like several nursing home people that have other things that are happening and going on. So it's just so important that they keep that next appointment that we make to decide. Because sometimes the decision, we keep putting it out farther and farther and farther.
But we have to track that, that's the thing, is we have to have, if that first appointment is too much stuff going on, I've noticed that's where sometimes we have to make sure that we keep pestering.
Should we leave it 2 week? Should we keep it a 2-week follow-up and
I
leave it
don't
out?
know, do you think it should be longer, Dr. White, or no?
Like the reason we made it 2 weeks was because of the ones that would be like that one I passed around, that filter I passed around is an Optes. We'd be reluctant to leave that one in permanently. We put that one in because it's so easy to retrieve from below. We usually do that for orthopedic procedures. So if you put that in, that better than come out. And so it should come out in 2 weeks. So the initial thought was see everybody back in 2 weeks, because if they have one of those, we want to make sure it comes out.
Seems lately most of them are select filters that have to come out through the neck, right?
Yeah, we've been switching to select because we didn't want, there's a higher rate of migration and long-term problems from the Optes. So,
Which one's the select? I don't see that here. It's a cook, okay.
It looks more like a bird's nest.
So you take them out through the jugular?
Those, yeah, the Optes you can take out through the vein.
I see.
There's a femoral vein, but that one you have to fix up here.
So if a patient's the no-show, Ann, what do you do special? Or
Well, if they're no-show, like the schedulers, get them scheduled for another appointment. We
Okay.
had one that was at a nursing home that I think scheduling had to reschedule like 3 or 4 times before she finally came. But they do, the scheduling gets them back.
How do we do that?
It's not the best method, because what's happening with no-shows is what I've been researching. I'll have to talk to scheduling, because we gotta get them in, or they need to, if they can't get a hold of them, they're gonna have to make a telephone call and route it.
Well, to me, there's 2 backups to this. Number one, Paul tracks all the filters that
Right.
put in. So we
Right.
have backup to check, to make sure that we've got all the people we should be following. And then the other follow-up is the registry. So that whoever's filling out the registry, when they go back, should review that once a month, that every person there should have some sort of follow-up. So if the registry's not complete, then the person that's doing the registry should call scheduling and say we need to make an appointment with this person.
Which I
in the
make a
registry,
telephone
we
call.
have, okay, good.
What I do is if I see they don't have an appointment, because when I see a no-show, I can open up and see how many times they try to reach them, and then they just quit.
Yeah, we can't do that.
And yeah, so they don't send anything on. So I think we're gonna have to figure out another layer. So
Liz
then,
is our scheduler, and she's great at whatever you need her to do.
yeah, so I'll have to talk, I'll go through city stalls and go from there.
I guess the exception would be if someone's on hospice.
Right.
So if someone's on hospice, you could use common sense and document that their life expectancy is shorter.
Well, by definition, it's supposed to be 6
Yeah,
months,
they
so.
don't need to have the filter.
And I have one that they declined in and the family declines, the nursing home physician declines. So I just have it documented, so.
We had one that was a nursing home that took a long time to get in. And when she finally got there, we found that the hospitalist, when she went home from her GI bleed, just stopped her aspirin and her Xarelto. So she'd been at the nursing home all this time on no anticoagulation, just with her select filter. So we had to find out from Harani if it was okay to resume anticoagulation, and it's kind of complicated.
It
And I
is.
think I
That's
just sent that to.
That's a good example of what we need to do,
Oh
because the
my,
whole
it's just a
thing was
mess,
screwed up.
yeah.
Denise, can you set up, when you put in the initial order, that it goes into a work queue for the registry?
We could, but Paul does it, so it just works, it works so well. And they're building a new registry, and it'll all be automated. So I don't wanna add another layer to Ethel, because we're almost done and.
We're getting
taken
close.
care of.
We won't live to see that if we do any more.
What's that?
We won't live long enough to see that happen.
I think
We're getting close, Dr.
Yeah.
White. Trust me, I've had the same doubts, but I think we're getting close.
Dr. White, if anybody's like helping their physician set this up, as far as like the anticoagulation that the patient's on prior to removing the filter, if it's select, if it's the Optis, some people aren't holding anything at all, but if it's through the neck, you need to for bleeding. So I don't know if there's a parameter or a guideline that
Well,
we could
here's
follow.
what we did, so.
Because it depends on who's doing it.
Well, we had a meeting of the
Yeah, we're not supposed to
physicians
hold
putting
them.
them in, and we all decided that we weren't gonna hold anticoagulation.
For neck or
For neck.
other.
Yeah.
And so, and then I heard one person complain one time when they came in there, anticoagulation wouldn't help, so, but we've decided that anticoagulation doesn't need to be held, but we should, if they're on Coumadin, we should check an INR the day of procedure, because if it's a 9,
Yeah.
probably wouldn't take it out, but if it's therapeutic, we would
Got it.
take it out. It's still compressible,
Right.
so we don't tend to worry about it. It's a big sheath, it's a huge sheath, but we don't tend to have problems with the
Well, good,
big
that's
sticks.
good to know, because I hear different things still all
I
the
know,
time.
like last week I scheduled a removal and I was told to hold Xarelto for 2 days.
So which, if you're told that, that's fine. Our
Right.
general policy is
No.
that not to hold anticoagulation. But if someone's doing the procedure and they make that request, well, that's fine.
Okay.
And the thing is, it's ironic,
Well,
it's
that's why I
like,
didn't know if we need to ask, like, we don't have to ask the individual physician that's removing it, right?
in theory.
Okay.
In theory, we've agreed on that. The ironic thing, like you say, Ann, is like what irritates me, if someone had a filter placed, and they shouldn't go home on anticoagulation, because the reason they got their filter placed was they can't tolerate anticoagulation. So if they've already gone home on anticoagulation, they should have that filter taken out in 2 weeks when they see you. So I don't know, you can monitor to see if 2 weeks is too early, but the ones, we definitely don't want to leave a filter in somebody that had an orthopedic surgery who's a young guy who would be terrible if it had stayed in forever. And the longer that's in, like after you want to take that out as quick as possible to make sure it comes out. So that was the rationale for the 2-week thing, was we didn't want to have some young guy that had a knee replacement leave his filter in for 2 months and then not be able to get it out.
And two, a few people, you yourself have ordered like venous duplexes in our office prior to making the decision.
Yeah, so sometimes if they have, that's to determine whether they have still ongoing risk factors. So someone that can't tolerate anticoagulation, that had a DVT, that you're not quite sure why they had a DVT, and if they still have active DVT and swelling, then they probably have an ongoing risk factor, a chronic ongoing risk factor for developing more DVTs. And if they still can't tolerate anticoagulation, then they probably should have the filter left in.
So it's unprovoked, probably.
If it's unprovoked, so here's the thing, if someone had an unprovoked DVT and they come back in 3 months after their anticoagulation, 3 months with a filter in, they still have bleeding problems, but they don't have any more risk factors for another DVT, they could have the filter taken out. But if they come back in 3 months and still have a lot of swelling and a DVT, then their recurrence rate's high, and so they probably should have the filter left in. So those are the ones that are kind of difficult to determine whether they should